Hello, my name's Deborah Armstrong. Today I'm going to give you an introduction to binocular vision anomalies, how to test for them, and how to manage these conditions in your patients. I'll be concentrating on the examination of adult patients. Examination of children is a whole different ballgame. When a person has normal binocular single vision, their visual system is able to use information from both eyes to produce a single image. The foveas of both eyes fixate simultaneously on the point of interest. If the development of the binocular vision system is impaired, each eye may fixate on differing points, and this might result in the suppression of the image from one eye, so the brain perceives a clear image from one eye only. Another adaptation to impaired binocular vision development is the development of abnormal retinal correspondence. Impaired development of the binocular vision system leads to the stereopsis of the individual being affected, and this in turn affects the ability to judge depth, speeds, and distances. If a system that's developed normally suddenly fails, this might result in diplopia or double vision, although in time adaptation in the form of suppression might occur. I've included this slide to demonstrate how disconcerting the experience of diplopia can be to the patient. Other animals, as well as us humans, also enjoy binocular single vision. Can you work out which of these animals have got good binocular single vision? Yes, that's right. They're the ones who have eyes that point forwards, i.e. in the same direction to our own. These animals are all predators, or at least they're descended from predators in the case of the dog and the cat, so they need to be able to judge speeds and distances well. The other animals all have eyes placed on the sides of their heads, not so good for judging speeds and distances, but great for being able to see all around you when you're likely to be prey to all the animals with the binocular single vision. Accurate functioning of the binocular vision system is dependent upon the information received from each eye being integrated to give a single perceived image. Anatomical abnormalities can interfere with this process, whether they be developmental or whether they be acquired through disease or trauma. An anatomically normal motor system might have functional abnormalities, and these may also result in visual disturbances that cause the binocular single vision system to break down. For example, uncorrected hyperopia can lead to excessive accommodative effort, which in turn leads to excessive convergence and visual discomfort. Abnormalities within the sensory system might result in reduced clarity of the image from one or both eyes, and problems with the sensory system might be accompanied by adaptations. This could take the form of suppression, abnormal retinal correspondence, or amblyopia. Don't worry if you're not entirely familiar with all the terms that I'm throwing around. By the end of this series of lectures, you should be familiar with all these terms, and you'll also be able to understand how to manage them. An assessment of the binocular vision status of every patient should be made during an eye examination, regardless of whether the patient's history and symptoms suggest that there might be a problem in this area. Often, binocular problems, especially sudden onset ones, are accompanied by symptoms that the patient will tell you about. However, because of the visual system's ability to make adaptations to these anomalies, your patient might not even be aware that there is a problem. The law says that when carrying out an eye examination, you should carry out assessments necessary to detect abnormality, and that you should use your professional judgment to decide which assessments to use. The law is in fact quite vague in its requirements, probably so that professional judgment isn't stifled. However, the College of Optometrists has guidelines that are much more specific, and I think these are very useful. Assessing binocular status with a cover test is listed as an essential part of the eye examination, with additional binocular vision tests to be included if they are clinically necessary. It's also worth noting that the ability to perform and interpret the results of these tests is part of the GOC core competencies. Over the next few slides, I'll indicate why we need to collect a thorough patient history and symptoms with respect to binocular vision problems. I'll also highlight the importance of associated conditions and clarify the meaning of some of the related terminology. A thorough patient history of both ocular and systemic conditions can be very useful in helping with differential diagnosis. Often, an experienced practitioner can make an accurate tentative diagnosis from these questions, and the tests performed on the patient are merely to confirm the initial train of thought. It's very important to observe your patient as they enter the room. This can give you information before you've even started to ask them any questions. Consider how your patient's walking in. Are they unsteady on their feet? This could mean that they have dizziness symptoms, which might be linked to their binocular vision status. Of course, it could be due to other factors, but you need to be aware of the possible ocular implications of unsteadiness. Do they have a head tilt or turn? Some patients compensate for a muscle imbalance by habitually adopting an abnormal head posture. For example, diplopia caused by a right lateral rectus palsy can be alleviated by turning the face to the right so that the right lateral rectus is not required to contract. You should, of course, always bear in mind that an abnormal head posture doesn't immediately indicate binocular vision problems, as a patient might have another condition such as a unilateral deafness, and they're turning their good ear towards you so that they can hear you properly. Visual field restriction might have a similar effect. On the other hand, they might just be shy or have developed a habit. If the retinoscopy reflex fluctuates, that can indicate fluctuations in accommodation. And in these cases, you should consider latent hyperopia or pseudomyopia. Finally, if the patient seems disconcerted when you take away the occluder at the end of a monocular refraction, then a binocular vision problem should be considered a possibility. If a patient tells you that they've got a weak eye, a lazy eye, a squint, or an eye that turns, you should then ask if any treatment such as patching or surgery was being performed and how old they were when this happened. Eye injuries might result in strabismus or sensory adaptations, so it's important to ask how long ago any eye trauma occurred. People with a family history of lazy eye or strabismus are much more likely to have these problems. Of course, when speaking to patients, you shouldn't use the word amblyopia, but use the word weak or lazy eye. Strabismus might be better described as an eye that turns. Some systemic conditions, such as diabetes or thyroid eye disease, can cause binocular vision problems, and these should always be noted. Systemic problems affecting the eyes will be discussed later on in the programme. How to take a patient history is discussed in another lecture. With patients who complain of blurred vision, headaches or asthenopia, a problem such as decompensated heterophoria or accommodation excess or insufficiency should be considered in the differential diagnosis. Symptoms of occasional diplopia might indicate that a phoria is breaking down into atropia, or it could mean that the near point is too remote, or it might mean there's an concomitant deviation. Just be careful to ascertain exactly what the patient means by double vision. Some people use the term to indicate blurring or ghosting of an image, and this can lead to confusion unless the practitioner clarifies exactly what the patient means. You also need to find out whether the diplopia is horizontal or vertical, and whether it's binocular or monocular. Sometimes people with a binocular vision problem will mention that their distance vision's blurry after they've been reading for a time, and this can indicate a problem with the accommodation system. Teachers often ask parents to have their child's eyes tested if they're making slow progress at school, and this can result in a diagnosis of binocular vision problems. Hyperopia is frequently associated with children who are struggling in class, and a refractive correction can make huge difference to that child's progress at school. Finally, it's important to remember that the absence of symptoms doesn't necessarily mean that there are no binocular vision abnormalities, since there's a number of adaptations that the visual system can make to overcome these symptoms. These will be discussed in lecture 4.10C. Here's a reminder of the mnemonic that's useful for investigating symptoms. When a patient has told you about something that they're not happy with, you should dig deeper and find out exactly what's going on. This will be discussed further in your history and symptoms lecture, and it's also gone into in a bit more detail further on in this lecture series. So to be able to tell what's abnormal, you first need to know what's normal. For the purposes of binocular vision investigation, I would say that a patient is normal if both eyes are fixating at the same point in all directions of gaze, and they don't have any symptoms such as headaches, blurring, diplopia, etc. Normal values must be taken as a guide and not an absolute value. The accommodation table on page 180 of the latest version of Elliott's book, Clinical Procedures in Primary Eye Care, shows that different studies came to differing conclusions about what normal values for the level accommodation are. I've reproduced part of the table in this slide so that you can use it as a rough guide. The term fusional reserves refers to the maximum amount that the eyes can converge or diverge. If a patient has aphoria, some of these fusional reserves will always be used up by the sensory fusion reflex to correct the deviation. It's thought that between 1 and 2/3 of someone's fusional reserves can be used up without putting undue strain on the system. Lecture 3 discusses how to measure fusional reserves. And as a guide, I've reproduced the table from page 176 of Elliott's book. You can see that these values show that the positive fusional reserves are greater than the negative ones. When a patient is tired, they might struggle more than usual to maintain binocular single vision, especially if they usually use a significant portion of their fusional reserves to keep everything single. A good analogy for this is to imagine doing a long session of weightlifting in the gym, and then having to go back to the gym and lift the same weights before you've recovered properly. You're going to find that second session much harder to complete, and your muscles might simply not be able to deliver a decent performance. An uncorrected refractive error might mean that a good proportion of your accommodation is being used to keep that image in focus, and this can lead to fatigue and possible difficulties in maintaining focus when tiredness kicks in. An overcorrected myope can experience fatigue for similar reasons. I don't need to tell you, as you're all dispensing opticians, about the prismatic effect at different distances by different prescriptions, and this might reduce or enhance the fusional reserves. Finally, if the PD and centration distance of the spectacles differ, the induced prism might be enough to cause symptoms in a patient who is already on the limit of their fusional reserves. I imagine that your previous training will mean that you're familiar with many of the terms that we use in binocular vision assessment. I just want to go through this one though, as you might not have come across it in much detail, and that is commitancy. A commitant deviation has a constant angle of deviation in all directions of gaze. An incomitant deviation differs depending on which direction of gaze is being used. This is discussed in more detail in the ocular motility presentation, which is later in this section. Measurement of commitancy and non-commitancy is covered in week 11. I'm sure you'll be familiar with the term dominant eye. This means that visual information from one eye is processed in preference to the other. Not everyone shows a dominant eye, and some studies have shown that ocular dominance is plastic. It's commonly believed that it's easier to accept monocular blur in the non-dominant eye. If the dominant eye is slightly blurred, it might give greater level of symptoms than if the other eye is blurred, and this is something that needs to be taken into account when prescribing changes in prescription. To find out which eye is the dominant eye in your patient, I prefer to ask the patient which eye they'd naturally choose when taking a picture with a traditional camera, or if they were using a telescope, which eye would they use to look through? Many tests for ocular dominance have been shown to give ambiguous or unreliable results, and there's often weak agreement between different tests, so you might not be absolutely sure that you've chosen which eye the patient's happier looking through. That's all for the first part of the introduction to binocular vision in adults. In the next few presentations, we'll be covering tropias, phorias and extraocular muscle actions, and how to measure these in practice, as well as management of basic binocular vision problems. More advanced binocular vision management is covered in lecture 4.10C. Thank you for listening.